morning.
Good morning.
Welcome to the Department of Medicine Grand Rounds. Today we have a special lecture on diabetes, which I promise you will be great, given by one of our extraordinary endocrinologists, who will be introduced in a few minutes. Before that, a couple of comments. One, we had a long discussion about Ebola and our response during our Tuesday faculty forum. The ID group is charged with putting together some recommendations for the Department of Medicine. We have some key champions, what I call Ebola SARS, for the VA, for University Hospital, and for University of Louisville physicians. You will be seeing more of that information in the next couple of days, okay? Number two, I wanted to let you know that about 300 years ago, in 1708, was the birth, on this day, of Albrecht von Haller. And von Haller was a Swiss biologist who was a father of experimental physiology. At the time of his death at age 69, he had made significant contributions in physiology, anatomy, botany, embryology, poetry. He had recognized the mechanism of respiration, the autonomous effort of the heart and its function. He understood that bile helps digest fats, and he wrote some of the original descriptions of embryonic development. He actually summarized studies on the brain and the cardiovascular systems, and he made contributions on understanding of nerve and muscle activity. So I was quite impressed with that. Almost 200 years later, in 1875, was the birth on this day, October 16, of Henry Sherman. Henry Sherman was an American biochemist who pioneered a number of assays that he used to look at vitamins and other food supplements that we take, and he actually developed the average human requirements for calcium back in 1931, for phosphorus, for iron, and vitamin B. In fact, his studies were the ones who were really used for many, many, many decades as the ones who defined the human daily requirements for these substances. He also identified iron deficiency anemia and began studying cobalt in 1946. But today is about endocrinology, so I have to tell you about an endocrinologist, Hans Seelye, and I don't know if I'm pronouncing that correctly, it's S-E-L-Y-E, who died on this day in 1982. Hans Hugo Bruno Seelye was an Austrian-born Canadian endocrinologist who studies stress. Talk about relevance. Seelye first detected the effects of stress in 1936. He injected ovarian hormones into rats, and he found that when doing that, he stimulated the outer part of the adrenal glands in rats, and it caused deterioration of the thymus gland, and he produced ulcers and finally death. Then he started studying other toxins, and he found that they all did the same thing. Then he started causing physical injury to the rodents, and he found that the same things. And ultimately, environmental stress caused the same things in the rats. In humans, Seelye demonstrated that stress induced a breakdown of the hormonal system, and this could lead to a number of conditions such as heart disease and high blood pressure, and he called all these diseases of adaptation. Diseases of adaptation. Are we suffering of diseases of adaptation? And with that, I'll leave you with Dr. Betty Villaferte, who's going to introduce our speaker of the day.
Hi, our speaker for today is a colleague of mine, Dr. Sathya Krishnasamy. Dr. Krishnasamy is an associate professor of medicine here in our university. She is also the associate director for our fellowship training in endocrinology, the director of our UofL AIM Endocrine and Diabetes Clinic, the medical director for our employee chronic disease management. So if you have any university employees or their dependents that have diabetes, we have a program for them in which they will get a lot of discount and good care, okay? Dr. Krishnasamy also is the PI on several industry-sponsored grants studying the development of certain drugs in diabetes. And she is an invited speaker for many medical and community organizations in the Kentucky area, including a guest speaker episode at NPR. Today she's going to talk about the updates on the recent developments in diabetes. And the title of her talk is The Year in Diabetes, Bags, Bionics, and Broken Hearts.
I hope everybody can hear me. Just one correction in your very nice introduction. I'm not responsible for the whole chronic disease management. I think Dr. does a great job of that. I just take help with the diabetes part, but thank you for that. So we have a lot to cover, so I'm going to be going a little bit fast. This year and the last few years have been a great time. It'll go down the history of diabetes as the golden era. We are quickly from having very few drugs and very little, one or two options with insulin, we've quickly progressed all the way to several options, several gadgets, and several interesting things going on. So I felt that this was something important that I had to bring it to my colleagues here. So I have no conflicts of interest. I'll be showing a lot of devices and medications, but I have no personal interest in that. So when you're here today, I want you to think, I'm sure many of you have been, when you go to Walt Disney, if you've ever been there, with little kids, the one area I really liked, this was more than 10 years ago when my child was 5 years old. My son doesn't want to go to this. It's called It's a Small World After All. So you go through, you sit in that little boat, and there's these little kind of scenes, and you just pass through it. That's what we're going to be doing today. I'm going to show you little blocks. We're not going to go through everything. We're just going to get a glimpse of it. But if you need to learn more, go up to 3rd floor to Kelly Gallery, sign in for the MEC Wednesday evening, 4 o'clock, and we'll have throughout the year great speakers, great topics. Dr. Winters, my chief, does a great job of putting that together. So anybody who talks about diabetes, I feel like should show this slide. It's a tribute to everyone in the audience. I see people nodding their heads. It's Banting and Best in front of their laboratory. These are the 1923 Nobel laureates. This lecture, I wanted to tell the students, is on the website, nobel.org. It's one of the best lectures ever delivered. The Banting lecture, every year now, at the American Diabetes is awarded to someone who makes great discoveries of strides in diabetes. So I have to offer my salutations to these great groups in insulin. So we'll talk about a case-based format, looking at quickly going over the changes in the guidelines. There's no way I can cover 67 pages of the ADA guidelines, but for those of you who are interested, every year in January, Diabetes Care has a supplement, and that gives the year's guidelines in diabetes. And it's very, very, very detailed. It's done by several experts in the area, international and national experts. It's for everybody. Can everyone hear me well? And then we'll try to quickly go through the epidemiology. And one of my interests is ethnic differences in presentation of endocrine diseases. So I just want to touch 1 or 2 minutes on that. And then we'll, of course, I promise you to show some of the novel therapeutic agents. Many of you would be familiar with it, but we still will go through the ones that have been in the last 5 to 7 years, but mostly in the last year. And also, while I'm talking, I will just kind of add on what we do here in our program. So let's go on and start with our patient. Well, it's a midday at the Endocrine Diabetes Clinics at UofL. Me and Dr. Villafote, we have our role plates on. We're always running back and forth. And I have this 50-year-old male. who's been referred for diabetes management. And as you can see, his numbers is A1C 8.5. Everybody here will probably agree not the best control. His BMI on the side of obesity, blood pressure slightly elevated, and he is of ACE inhibitor at this time. LDL is 1 or 2, and folks here may recall the nice lecture given by Dr. Wagner a few months ago on the American Heart Lipid Guidelines. So he is on a statin. So and his urine shows some microalbumin, and he's updated with his eye exams and his foot care. And as always, every time I ask the questions about somebody who's heavy set, wider neck, about sleep apnea, and he's being good. So this is just an example of what our patients go through, their journey with diabetes over the years. So this gentleman here was on metformin, which you will see in the guidelines after diet and exercise and lifestyle changes within 3 to 6 months. If things don't improve, metformin is the first drug of choice unless there are contraindications. And sulfonylurea was added, and it's a potassium ATP channel blocker. And after that, because his A1C was still uncontrolled, he had been given rosiglitazone, or what we call as Avandia. And if you could recall, go back 6-7 years, this made the news. Steve Nason in the FDA panel talking about the meta-analysis about CV outcomes while on Avandia with the advanced trial. So, of course, he was taken off Avandia and then started pyridoxine. And he developed fluid retention with pyridoxine, although his blood sugars were better. And last year, in India and Europe, they took pyro off the market because of concerns about bladder cancer. However, in the United States, we didn't do that. We just kind of made a warning. So he anyway decided that he didn't want to do that. So then we go on and do the next step, which is add basal insulin. And of course, just like any other patient, and everybody here is aware of that, you get calls frequently. This insulin is not approved by this insurance, so can I switch to the other one? Can I do this? Can I do that? And this year, the volume of the calls have been really, really high with us. So he switches between glargine and denomir, which are available long-acting. And of course, during this whole process, his transaminases start going up. So, and it's up higher than 3 times the upper limits of normal. So we had to discontinue his metformin, cut it back, and then discontinue it. And I had to refer him to my GI colleagues, Matt Cave and Dr. Marsano. So, and then his sugars go higher than ever, so he's quite upset. So his insulin requirements, now we have to add basal insulin and bolus. His insulin requirements are higher, so it's over 250 units. So I have to do what every diabetologist will do here, which is add the mother of all insulins, that's what we call it. It's U500. It's 5 times concentrated per unit. So when I give somebody 20 units, it's 20 times 500 units. And many of the house staff here may be aware that at the university and at the VA, we have some guidelines set out for using U500 insulin so that endocrinology gets involved, or our inpatient nurse practitioner, Sue McGowan. So he goes on U500, and his sugars do get better. But he also comments here, which I remember from Dr. Vaidya, our guidance faculty, he always brings this slide on in his talks. Do I want to pay for my diabetes meds, or do I want to become a millionaire? So, and everybody here understands that. So the next thing he calls and he says, I'm gaining weight like crazy. I can't do this. I'm just gaining weight, which insulin is adipogenic. Most people, especially U500, they do gain. A1C improves, but they do gain weight. So, and of course, we discussed bariatric surgery, and he says, no, I want medical process, no bariatric surgery. So we go on into other novel options, which is where I leave him, and we move on to discuss a few words on epidemiology. The reason why I'm standing here talking to you We'll take a small tour around the world and come back to the United States. So the global prevalence right now, 2030, 382 million with diabetes. 2025, not too far from now, it's predicted that it'll almost double. And here in the United States, this was in year 2000, year millennium. Most of the areas in yellow, you can see Kentucky here is 7.4% prevalence of diabetes. And of course, move on 10 years later, 2010, here we are. Most of us here are coded red, especially the belt right here, southern belt, which is the same belt as the obesity belt, the kidney stone belt. Dr. Mehra, I promise we'll get the bone and stone clinic off the ground pretty soon. So this is how important it is. In fact, in Kentucky, some of the areas, some of the smaller counties, the incidence is as high as 12 to 16%. So it is a real public health and a global problem. When I made this slide a few months ago, I just had these numbers, but when I went into the CDC website yesterday, I noticed that these numbers went up even higher, which is the prevalence and the undiagnosed percent of diabetes. The prevalence right now is 21 million. It's gone up since 2011. And the undiagnosed also went up by 8 million to 8 million. So these numbers are much higher now than it was before. So the US prevalence is roughly, it was 8.3 2 years ago in CDC, and if you go on and look in the website now, it's 9.3%. So it is going up. And the most important reason for us to be worried is not just the diabetes part. I know Dr. Boli and his team are here, but it is the CV outcomes, and that's where my broken heart comes in. We're not going to spend too much time on it, but it's obvious to everybody the biggest issue with diabetes, the mortality and everything, is the cardiovascular outcomes, microvascular and macrovascular outcomes. And anybody who's interested in diabetes care needs to know about this study, which was a very elegant study done in the 80s, 10 years from 1980s to 1990s, funded by NIDDK, looking at type 1 diabetics, at that time with the given medications, which was multiple dose injections, basal bolus, versus standard care, which was premix insulin at that time. And if you look at this, the patients were in this study, about 1,400 patients with 9 centers around the nation. Patients were in the study for 10 years, and they had a 90% retention rate, so many of them continued to be followed 10 years down. Even last year at the ADA, these patients were honored, these patient volunteers, the subject volunteers were honored with a medal last year at the ADA, which is, we're talking about 1980 and last year was 2030, now almost 30 years. So if you look at the conventional treatment versus the intensive treatment, even though they start the active follow-up, but you can see the separation of the lines in terms of the cumulative incidence of cardiovascular mortality. It goes on, and that's why Dr. Mokshinam always tells, this is the gift that gives. It's the legacy effect or the metabolic memory. Get them in control early on, and it continues. The benefits or the returns continue for the rest of your life. And it's something you have to remember when you leave this place. I would like for you to remember this. And that's what I keep telling all my patients who have the new diagnosis every time they come in. So what is new or what is different with the ADA's guidelines? It's been since 2009 to today, the trend has become personalized or tailored to the patient medical care. That's the most operative word. Before, we wanted everybody, irrespective of how they were, what their comorbid illness was, what their age was, we wanted everybody to get to goal to 7% of the load. But now we've tailored it. So the emphasis is patient-centered care. There's a lot more details. Even yesterday, the ADA released some information about child care for childcare workers and parents. There's a lot of details on that. And gestation, women have a lot more focus. Gestation, in fact, they have cut off clearly ethnic group based raised cutoffs for GTT in gestational diabetes, and elderly, 80 and above, multiple comorbid illness, high risk for falls, a high risk for hypoglycemia. You don't need to treat them to below 7%. You can get them to 7.5 to 8%, or whatever you feel is important for that patient to achieve safety, goals to achieve safety. And of course, to highlight ethnic differences, the ADA over the years has been big about recognizing that in endocrine diseases, in diabetes, that racial and ethnic differences do matter, especially the waist cutoffs. I know Dr. Dept has worked on some of this in his previous institution, but it's very important, especially since now in Louisville we are becoming more metro, we are becoming a melting pot of cultures, and those fellows and house staff in the ACB clinic know that we see a lot more of immigrant patients, refugees, so it's important to keep this in mind. And also, we do talk about cancer and diabetes because it's always been a concern with higher incidence of cancer in diabetics, and fractures, because we did recognize bone biology in diabetes in the past, but now we know more and more about it, and there's been a lot more interest, what inflammation does to the bones. We used to think that only type 1 diabetics were higher risk for fractures, and we used to screen them, but now we know that type 2 diabetics also have a higher risk. So they have highlighted that. And also, who can ever ignore the media about the T centers and the male centers? So they do have more information about androgen deficiency in men, aging men, and replacement diabetes. So I will switch this part because most of you know these cutoff numbers that we use in the interest of time. So next, moving on to the most important thing that we have to do with diabetic patients. The first thing is diet, which has to continue throughout the treatment, whatever else you offer them. It's very important that they do understand that lifestyle changes and diet, a formal diabetes self-management education program, and a medical nutrition therapy is important, and it's integral part of diabetes treatment program, and that's why the employee program is very important, because we have members from Tina and Paula Kumar who work on these patients, do education, and kind of support them, follow them, and help us in the process. So I just mentioned that we do have this wellness program, and in fact last year we applied for a recovery grant, and we're hoping to able to reapply for the grant again. There is a patient is the center of it, and physician, health educator, and a wellness coach. So, and it's part of the UPCP, or the University Patient-Centered Project, or the SUN grant. We already spoke a little bit about less stringent for patients who are higher risk of hypoglycemia. When they have long-standing diabetes, everybody here probably remembers that COD trial, long duration of diabetes, higher risk of hypoglycemia, even in the VA diabetes trial, VADT. So life expectancy shorter, less stringent goals, and important comorbidities, if they're absent, tighter control. Very severe comorbidities like severe autonomic neuropathy, hypoglycemic unawareness. Those patients you do not want to get tight control. And also vascular complications, and this is where the CORD comes in. So just to summarize, the medical care, while you control the blood sugars, what is more important is also the other covariates, which is hypertension, cholesterol, antiplatelet therapy, diabetes, kidney disease. $11 billion, 2011 was the expenditure. 50% of patients in dialysis, the reason is diabetes. So it's a very expensive disease. This year, there's a nice supplement in diabetes care on diabetes, kidney disease, and recommendations. So I encourage you all who are interested in this to read it. And eye disease, neuropathy, diabetic gastroparesis, peripheral neuropathy, cardiac autonomic neuropathy. These are very important complications that we need to screen the patient regularly. And the fatty liver disease, non-alcoholic fatty liver disease, the incidence going higher and higher, the prevalence with the increasing obesity, and it's expected that, or it may be already true, that the reason for transplant, liver transplant, the number one would be fatty liver disease and not be Hep C or hepatocellular CA. And vaccination, Hep B has been added. A few years ago, it's been 2 or 3 years, and the rate we talked about. And all of you here can look at these different studies which get coded again and again, landmark studies. So a couple of words on ethnic differences. Some of you here may recognize this pretty actress here, Salma Hayek, who comes from Mexico. So she belongs to the high-risk ethnic group. She also has a history of gestational diabetes. If I were to remove, if I had to believe the media, the information on the web, press. So, and other reasons to screen patients for diabetes, because anytime we talk about a very important disease, we have to mention how we prevent it, and pre-diabetes is something we have to screen all our patients for. Anybody with a BMI over 25, first-degree relative, or family history of diabetes, physical inactivity, which I could blame even myself with the electronic records. I'm always sitting and typing things and not doing more activity like I should. Polycystic ovarian syndrome, impaired fasting glucose, hypertension, acanthosis, the velvety kind of areas around the neck area, and previous history of cardiovascular disease, and age over 45 years. So this is something I wanted to highlight since we brought up the ethnic differences. The diabetes incidence is based on the 2011 CDC statistics. In Native Americans, Alaskan Natives, it's about 16%. Hispanic Americans, it differs between different groups. As you can see, in Puerto Rican, Mexican Americans, 13%, and in Central South America, it's actually 8.4%. Asian Americans, it says 8.4% here, but those who all take care of Asians know that all Asians are a little bit different. So the Asian Indians have a higher percent of 14% compared to some of the other Asian origin. And this is a slide, every time I show the people, they get all excited, so I thought I'd just add it, although the study is from 2006. If you can look at these two, and this is actually the Dr. Barnett, this is from England, and this is one of the patients of Indian Pakistani origin. The BMI, as you can see, is the same, but look at the body fat on the DEXA. This gentleman's body fat is 21% as opposed to Barnett's is about 9%. So the BMI alone cannot be used to categorize somebody for high risk for diabetes or metabolic syndrome. And we do, with increasing awareness and with several health fairs and everything, we are pretty active. Our group, we do volunteer. The Latino Coalition Health Fair is South Asian Indian Health Fair, and we do screen for metabolic syndrome. In fact, recently, from last year, from our study that we did at the Hispanic Coalition, these are the numbers we have for metabolic syndrome in the group of patients, about 60 patients who are there. Our fellow Dr. Carr put the numbers together here. As you can see, this is the national statistics, and this is our study population, which is looking at the various attributes of metabolic syndrome: waist circumference, fasting plasma glucose, blood pressure, triglycerides, and HDL. So it is quite starkly different, so it's important to remember that. So we'll move a little bit further, go to the novel agents, and this slide is available on the ACE for everybody to look at. That's American College of Endocrinology. It gives kind of a roadmap of what I explained to you, what our patient went through with his journey with diabetes. It started with lifestyle metformin, then we added other drugs, and then we are moving on to this one of the drugs I promised about the beast. So here we have the beast, and it's a Gila monster from the Mexican desert. And the issue is I always tell everyone, fellows, it's a multidisciplinary disease, interdisciplinary, and this is a GI gastro-based medication that I'm going to talk about, which is the incretins. If you look at, this was a study done in the 1960s, but for us to get the drug to use, it was mid-2000s. That's how far it took to get this drug to the market. So blood glucose, oral blood glucose tolerance test, and IV blood glucose tolerance test. So this is the response of insulin. You administer glucose, either PO or IV, and the response with insulin levels in the blood in a patient. With oral, you get a much higher response of insulin as opposed to diabetes. And this area here is called the incretin. The step effect is called the incretin effect. And this is produced, the incretin or the GLP-1 is a gut hormone produced by the flash-shaped L cells in the intestine. And it comes up as a pro-glucagon, and it's cleaved into GLP-1 and GLP-2. Surprisingly, GLP-2 does not have much effect on the insulin, but GLP-1 is the drug that we are interested in. And the same way, the gastric inhibitory peptide, which is also an incretin, is cleaved, and you get GIP, which is gastric inhibitory peptide. These two are very insulin-trophic medications. So I wanted to talk a little bit, because one thing about the insulin is, about 60 years ago, the way it would say was glucose would go into the beta cell, there'd be a big black box, and then insulin would come out. You didn't know what happened, and now, over the decades, now we know what exactly happens when glucose, through the GLUT2 transportation, gets into the beta cell. And here we have the GLP-1 receptor, the cognate receptor, GLP-1, and the GIP receptor. So through the adenine cyclase activation, this activates the cyclic AMP. It's through the G protein coupled receptors, cyclic AMP, and when the cyclic AMP levels go up, that stimulates the closure of the potassium channels, because there is an ATP mediated potassium channel. The potassium channel that causes the membrane depolarization. When the membrane gets depolarized, the calcium channel opens. It's a voltage channel. So when calcium opens up, it goes and aggregates all the insulin containing secretory granules together, and it releases insulin. And when the insulin is released, and then it leaves the cell, and then you have all the effects. And the same thing happens when glucose comes in. It's converted to glucose 6-phosphate, and the same thing happens. It elevates ATP levels, and the same mechanism. So many drugs have been developed based on this. Just so that you all know. So GLP-1 has very varied effects in the pancreas. It causes insulin secretion. I just showed it to you. And it also suppresses glucagon, which we all like in type 2 diabetes. Lower glucagon is good. And it also, there's other actions that it has. One of them is beta cell proliferation and decreasing beta cell apoptosis. Apart from the incretin effect or insulin stimulation, there are other effects that it has been touted to have. One of it is that perhaps the vasculature in the brain, in the heart, they all have GLP-1 receptors, and it stimulates or improves insulin resistance in all these areas. One of the trials that we have ongoing in the VA, 5-year trial, is looking at the CV outcomes of one of the drugs developed based on the GLP-1 mechanism, which is liraglutide. And I'm excited because this year is the 5th year, early next year, and we'll be getting more results in the final. And that will be the first longitudinal 5-year CV outcome result on this group of medication. So it will be interesting to know. And whenever you develop a drug which is analog to whatever is endogenous, you always want to know if the endogenous hormone can be held on to longer, because anytime your own hormone is better than something you get from outside, if the endogenous can be held on longer. So that's when the mechanism of the DPP-4 or dipeptidase peptidase 4 inhibitors, because the DPP-4 actually inactivates the endogenous GLP-1. So the DPP-4 inhibitors, in a way, stop or inhibit the GLP breakdown and increase your endogenous level. So that's the mechanism behind these two incretin mimetics. Well, anytime there's a diabetes drug in the market, there's always a lot of press about it over years. And of course, this one here, and these are some of the drugs developed on this, the names are here. And anytime there's a drug in the market, there's always some excitement about what goes on with it. And of course, many of you all must have heard about all the information about the pancreatitis, heart failure, and other issues, pancreatic cancer. Like one issue it would come as why is it bad for your pancreas? And the next one, that's Peter Butler, who's an islet biologist. The next issue will say, why is it beneficial despite all these other things? So it was going back and forth, and there was a lot of concern. So last year there was an NIH consortium meeting in summer, and also the FDA and the European Medicine Agency together released a report telling that while there's a higher incidence of pancreatitis in patients, however, it's no higher than other diabetics who are not on GLP-1, and patients who have type 2 diabetes, long-standing, uncontrolled, have inherent higher risk for pancreas disease. So we are continuing to use the drugs. And one thing that happened last year was the SAVOR TB53 outcome trial looking at observational study looking at diabetics on a drug, DPP-4 inhibitor called saxagliptin in the market. And there was a concern that there was more heart failure in these patients, or they were frequently admitted for heart failure. So there is some concern that saxagliptin or DPP-4 should not be used in patients with advanced heart failure. So those are some of the concerns about incretins. We'll go on to my next favorite area, since Dr. Leder is here. And that is the next mechanism of drugs developed within the last year. And this drug has had a lot of excitement and a lot of press. And Dr. Villafote's favorite drug. So there's two glucose transporters in your kidney. One is the GLUT family. It's mostly passive transportation. And the other one is SGLT, sodium glucose transport family. That's SGLT 1 and 2. And I'll show you the picture in the next slide. So if you are, the SGLT actually causes reabsorption of the glucose in the tubules. So if you could develop a drug which inhibits reabsorption, and you could have glycosuria and lose all those grams of glucose from your blood into the urine, thereby improving insulin sensitivity and also causing some weight loss, that would be great. So that was the concept behind this drug. And so there it is, SGLT1 and S2. SGLT2 causes 90% of the reabsorption, and so hence this drug that is in the market, or series of drugs, have been developed based on that. And the A1C reduction has been, according to the studies, about 1%, but I can tell you in some patients we're seeing a lot more than that. Of course, just like any other drug, there needs to be some caution when using these medications. As you can see here, one of the drugs here, SGLT2 inhibition, so there's reduced glucose absorption and increased glucose excretion here. And the caution with increased myocardial infections, UTIs. So if somebody already has problems with the current UTIs, it's not a patient that would ever take this drug to. Also, patients get easily dehydrated because of the large glucose load that's excreted. So caution has to be expressed with this, and hydration status has to be monitored. So we'll move on to the next area, which is the gut microbiome. I will spend very little time on this because I know there's experts in the audience and there's who do studies on it. So I won't. So the bugs got a lot of attention in the last few years. Do you have the good bug or the bad bug in your gut? So one of the studies which I wanted to highlight is this study from 2013 Science. It's quite interesting because they transferred microbiota from identical twins into mice. And the obese twin, the microbiota transferred from the obese twin, the mice became obese. So you could actually cause obesity by transferring somebody's bug into another person. So that was the whole concept of this, which is kind of interesting. And the concern is this, the gut microbes, when there's a change in the milieu of the gut microbes, that there could be what is called as a metabolic endotoxemia, so thereby causing problems such as obesity, diabetes, and also I know we already have fecal transplants being done for C. diff and autoimmune disease and all that. So the gut microbe has developed a lot of interest. In fact, in a week from now, actually, Dr. Mokshadana will be going to the symposium in Chicago. ADA and JDRF have a combined symposium looking at the gut microbiome and diabetes. So it has become very important these days as perhaps a source of treatment for obesity and diabetes. And so let me just skip this slide and go to the next part. So what are the things that we could do for changing the milieu to a better host, better microbe? And diet is one thing, and being healthy does help, Dr. Villafote. And certain drugs, there was one study looking at metformin changing the host drug bugs from certain other bugs to Akkermansia, which is supposed to be better for weight and for insulin resistance. And also, as I mentioned earlier, fecal microbial transplant, which there have been several studies. More recently, there's been interest looking at metabolomics or metabolic pathways in the genomic-wide studies, and gut microbiota have been looked at extensively. And this is some of the outcomes of the analysis. And one of it is that in diabetes, the butyrate-producing bugs, which are much better, butyrate is good for you. Butyrate-producing bugs are actually much less. The concentrations are lower in type 2 diabetes. And some of the other bugs, like lactobacillus and streptococcus mutans, are higher. And proteobacteria is higher in type 2 diabetes. And also, certain other, there's increased expression of microbial genes involved in oxidative stress. So there's a pro-inflammatory status, or what is called as metabolic endotoxemia in diabetes. But we still need a lot more data looking at what drugs do to these bugs, and also we don't know the male-female, the gender differences, and also mucosa-associated microbiota needs to be studied. Can anyone in the audience tell me what is common between these three? The Honorable Supreme Court Justice, the NASCAR driver, Brian Lee, and Mary Tyler Moore, who's the biggest entertainer of the 70s, I believe. It's type 1 diabetes. So, in fact, Mary Tyler Moore was the international chair for JDR research and has done a lot for diabetes. They asked from type 1 to we go to type 9. So we are going to quickly go through some of the updates in type 1 diabetes studies that have come, because there's a lot happened in type 1 diabetes. So the prevalence has increased across all ethnic groups in this, and there's a new antibody that has been approved for screening. We had GAD65 islet cell antibody, insulin antibody. So now we can add another antibody, which is the zinc transporter of the antibody. And also, when you screen a child who is a relative of a diabetic, when they're about, and look at the antibodies that we just talked about, the more antibodies they have, the higher the incidence of diabetes within 5 years, which we didn't know before. Prevention studies, it was thought that breastfeeding would prevent diabetes, and now we know from the studies we have that that's not the case anymore. And also gut microbiome. Type 1 diabetes also, there's major role in gut microbiome. In fact, there are some nice, elegant studies done in children looking at gut microbiome alteration in type 1 diabetes. And you have the highest number of beta cell proliferation, the highest rate of it when you're a neonate. That is something also which we know now. And if you look at this area and you're wondering, what is this? Well, the Joslin Diabetes Center in Boston, affiliated with Harvard, just handed out medals to their type 1 diabetics who had lived on for longer than 50 years. It's called the 50 Courageous Years with Diabetes medal. And there have been some studies done on these patients also looking at their cell status, beta cell status, glucagon status. And we have a lot of new things that we know about this. So everybody probably heard about this in the press last week. You know, what the group in Harvard had been looking at for years and years and years of trying to get beta cell out of the embryonic stem cell. Well, that finally happened last week. It was in the media. In fact, someone just approached me and they told me everything which I didn't even know. So one of the non-physicians, so I had to go and pull the paper and read it over the weekend and share it with my colleagues. So in the past, they had tried and tried and tried getting beta cells from pluripotent stem cells, but and from pancreatic progenitor cells. But now they use the embryonic stem cells in vivo and were able to make a beta cell with all the signaling mechanism, the one we looked at earlier, the complexities of all the ATP and the channels and everything. They were able to make it, and they were able to transplant it into a type 1 diabetic mice. And as you can see, the fasting glucose all the way. And I'll quickly show what happened here. This was the control mice, and this is the diabetic mice, which had the stem cell, beta cell developed from the stem cell transplanted. And this is the fasting glucose. And this is glucose in response to, insulin, here it's insulin in response to glucose. And glucose in the control mice, type 1, and the diabetic mice which had it implanted, and they also had another mice which had human beta cells implanted. So, and the insulin response was quite brisk. And this is a really big step in process. And the next is looking at the human trials in these patients. Well, the other exciting area that I wanted to talk about, spend a few minutes, is islet transplant, because now we do have the auto islet program. I don't know if the islet lab director is here. He said he was going to be here, but I don't see him. Dr. Bala. So with the efforts of Dr. Hughes from transplant surgery, and Dr. Mokshiganam, who loves islets. So we have an auto islet program here. So this was a picture from Dr. Bala. This is allo islet transplant, where you get a donor pancreas, deceased pancreas, and they isolate the islets. We have this lab now, the islet isolation lab, in the Cardiovascular Innovation Institute. And it is infused back into the portal vein of the recipient. And this is a very complex, the cell separator machine, and how they purify the islets, and finally kind of make a little stuff out of it, and then put it back in the portal vein. And now the program here is mainly aimed towards chronic pancreatitis patients. We have chronic pancreatitis patients who suffer from chronic abdominal pain, exocrine pancreas insufficiency. Many of them undergo total pancreas surgery, and when you undergo total pancreatectomy, you're rendered type 1. So they have complications such as DKA, there's extremely brittle diabetes, there's no glucagon and there's no insulin. So these patients really suffer. In this program, patients with chronic pancreatitis who have some reserve of islets left, which we test as endocrinologists using mixed meal test and some other testing. Then they undergo this, when they undergo the total pancreatectomy, it's called TPIAT. If you start seeing patients status post TPIAT, there is total pancreatectomy and islet auto transplant. And these patients then have this neat technique done so that they can be independent, have their own islets, and produce insulin. Even if they become insulin dependent later, but still it's not as brittle because there is some beta cell function in these patients. So this is a very interesting area of research, and I'm excited. University of Minnesota, Cincinnati, and some European countries had it, but now Louisville has it. So it is a great step in endocrinology. So I'll spend the last few minutes looking at technology because I trounced Bionics. So the one that I wanted to study was this summer. There was a lot of excitement about this bionic pancreas, and which is a closed loop system where in the past when we had to look at glucose control in type 1 children or adults, we had to keep them in an area where you could look at the numbers and then decide how much insulin do they get, how much glucagon do they get. If you had to simulate a pancreas, just like the pancreas works in your life. Well, Steve Russell from Harvard or Mass General this summer had this exciting study out looking at about 32 volunteers, some of them adults, some of them adolescents from a summer camp program, where they developed this, so the gadgets used were T-Slim pump, and a Dexcom Platinum. This is a Platinum Pro, it's very expensive. It's a sensor. This senses your interstitial glucose and feeds back to the pump. And also they used an iPhone 4S. So these patients would be able to go around, walk around, do whatever they wanted to do, travel. There would be a nurse with them all the time, which is one of the things. And the study was only for 5 days. However, the most important thing with type 1 diabetes is not getting the sugars to control, is avoiding hypoglycemia. Hypoglycemia can be pretty severe, can cause arrhythmias and instant death, especially death in crib syndrome in younger children. So that's a very important limiting factor to control. So these patients were able to continuously monitor their blood sugar, and were using the iCloud technology, got feedback from the nurses about how much insulin they would get for each. And at the same time, if they had hypoglycemia, they would also have glucagon used. It was a dual pump. So it was a great first step towards a closed-loop artificial pancreas. Of course, it was only 5 days, and it always involved a nurse making some decisions or helping these patients. But look at these numbers. This is hypoglycemia. And the hypoglycemia in the controls, which were patients before they got into the study, patients with their own controls, and later was much, much less. They spent a lot less time on blood sugars less than 70, which is very important in these young children and adolescents who have severe hypoglycemic episodes because they don't make any glucagon without a beta cell. So that was something interesting, a step closer to the closed loop or artificial pancreas. And we do have something similar in the market already with Medtronics. It's called the 530G last year. They do have a threshold suspend pump where when the sugar gets down below a certain threshold, the pump already suspends for up to a few minutes, and then it restarts. So that is the first time we have such a technology developed. So I just wanted to kind of move quickly and talk a little bit about what our program does, which we covered most of it. We have extremely busy diabetes clinics at the ACB. Jan Cox always tells us how busy our specialties, and I know Nancy Kubiak helps us a lot with many of these logistics and everything. And we do have a diabetes educator, registered dietitian who we didn't have in the past, so it's great to have that. And the employee program we talked about is Tina Claypool and Paula Kumar in the audience. And we did develop some inpatient hyperglycemia guidelines, and we were able to, with the help of Tom Juice and the IT department, we're able to get it in the reference section. And something very close to my heart, I'm very passionate about, is the Cystic Fibrosis Center provide endocrine care for these patients. And it's been a very positive experience for all of us. The team just came back from attending the national meeting, so they will tell me what happened there. And we do take care of all the transplant patients who develop diabetes, new onset diabetes after transplant. And thanks to all of Dr. Yusuf and Dr. Lederer and the hepatologists and all the referrals. And we have an active collaboration with the clinical chemistry. Dr. Miller is here, and Kairos Roby, one of our graduate faculty. Swapna Shifter had a very successful project with them. And the ILED program we talked about. But very important, the Diabetes Obesity Center. We have a very healthy, robust relationship, and we are moving towards the prevention diabetes center. And this is the spectrum of all diabetes. It's no size fits all. That's the dictum in diabetes. You can't see this part here, but it's the one mouse telling the other. They gave me Splenda and Equal and Splenda, and now I have artificial diabetes. So that's not in here, but every other. And CF, I did mention a little bit. I won't go too much into it because we are running out of time, and I want to have some time for questions. But cystic fibrosis is a multi-system disease, and diabetes is very important. And these are the numbers looking at hospitalization and mortality in CF when a patient with CF has diabetes versus no diabetes. That's the difference. So it's a very important disease, and CF centers have improved outcomes. So I'm going to skip this part due to interest of time. So we reviewed the tsunami of the diabetes epidemic, and we quickly went over the guidelines, so the differences or the major important points of it, and some novel agents that seem matters, technology, and either organ transplant, and this is a VA part. We do have a very robust clinical trial area, thanks to Indicate and Dept. And we do have some specialty clinics, pump clinic, bariatrics. We just signed off the thyroid ultrasound, so we should be getting that soon. So I just wanted to thank you all for your time. And this is in the Hindu scriptures, to the physician for the gods, or the divine physician, Dhanvanti. And he is the exponent for Ayurvedic medicine, original Ayurvedic medicine. So I always, in India, they always look to him, physicians kind of look to him to help the patients, to make best decisions for patients. And wanted to leave you with a closing note on Maimonides, who's a middle-aged physician and scholar for the Torah, author of the Torah. Treat the patient and not the disease. Thank you.
You didn't say anything about bariatric surgery.
I did have time. Plus, there's so much to cover, and surgery, remember?
It's not that that's true.
But we do have the bariatric, post-bariatric clinic at the VA. I did mention that we offer, that is in the algorithm in ADA, about patients who cannot, bariatric surgery is an option. Up to 6 years, they can be diabetes free, but we don't have too many longitudinal studies on that, but up to 6 years. But it is an option available.
I guess I'm kind of surprised that it is not pushed more. Because, just looking at least looking at the studies, I haven't done a huge comprehensive survey. When you look at the lack of success with weight loss, it seems like the bariatric surgery, number one, has a much greater success rate with the weight loss, and with the resolution, or at least partial resolution of diabetes. So
That's right.
I'm just kind of surprised it isn't like way up there, almost at the top of the list.
There are two components to it. One is that it's the patient's fear, any surgery, especially when you look at all the different surgeries. The most effective one is the rheumatology. And as you know, we have those patients that we follow. The long-term effects, the malabsorptive issues, and bone metabolism. And if you look at the data over time, many of them do, depending on how well they are part of a comprehensive multidisciplinary bariatric center where they can be continuously watched, nutrition, exercise physiology, behavioral psychology, where Barbara Stetson is not here, but she's great with that. And all those things were very important. And it's also the cost of it. Although when you look at one-time cost versus the cost of years and years of diabetes, but many times we do bring it up in patients, and many times the patients are a little resistant to it. They're okay with lab bank, but not with Lewin light, which is more permanent. There's a lot of fear as to, I won't be able to eat what I want, I enjoy what I have to do, and you hear from your friends and all that, and then, they make up their mind. But it is in the algorithm now in the last few years, since we had the Stampede study from Cleveland Clinic, which was one of the powerful longitudinal studies that showed the effect of diabetes.
A lot of information, and thank you for that providing. You missed out on the recent spotlight on the artificial sweeteners, and you also mentioned the microbiota, and interestingly, it connects that artificial roles in disturbing the microbiota in the gut.
That's right.
And I want to add here that in our blood, 25% of the metabolites, they basically are from the microbe in the gut. So what is your thoughts on that?
We have experts here, Dr. Marsano, Dr. McLean, who I had a great review. I was reading while I was preparing for the talk, and I know they have some studies going on looking at drugs and differences or the effects of the gut barrier dysfunction that happens, or the leaking of endotoxins and adipogenicity and effects on different pathways. But I think just like I showed those three areas, it's an evolving science. There's a lot of interest in terms of host milieu and how this is affected in adiposity and obesity and in type 2 diabetes and several other diseases that have been listed. And I'm not an expert in that area, but I'm sure there are other people who can offer comments on that. But it's certainly an evolving area, and that's why, while I'm not an expert, I wanted to bring it up so we will be aware of it. More questions?